Good afternoon, ladies and gentlemen. I'm Dr. Françoise Siroma from Action Against Hunger Senegal office, and I'm honored to present our study, the teaser trial, Effect of Integrating Household Water Treatment and Hygiene Promotion into the National Protocol for Management of Acute Malnutrition in Senegal. This study was carried out by a consortium of research and operational partners at the London School of Hygiene and Tropical Medicine, Action Against Hunger, and the Laboratoire de recherche sur les transformations économiques et sociales of the University of Sheikh Anta Diop. We implemented this study with the support of the Senegalese Ministry of Health, and this project was funded by the Bureau of Humanitarian Assistance, the Sense Foundation, and Action Against Hunger. The motivation for our study was the simple yet profound reality. While community-based management of acute malnutrition has increased coverage and improved some outcomes, recovery rates vary considerably across settings, ranging from 30 to 85% in the published literature. One reason for this may be that domestic wash conditions vary considerably and exposure to unsafe wash at home may limit recovery rates among some patients due to the associated risk of enteric diseases. Building on a limited literature, our study therefore aimed to assess the marginal benefits and marginal cost of integrating a wash kit within the National CMAM protocol as well delivered through the health system. The design of the study is a cluster randomized controlled trial of 86 health centers, and the aim was to assess the effect of the wash kit on some recovery and other related outcomes. And it included additional economic evaluations, environmental assessment, and acceptability sub-studies. The trial consisted of a control arm in which enrolled children were followed according to the national CMAM protocol, where uncomplicated some cases receive outpatient treatment that includes ready-to-use therapeutic food, antibiotics, and deworming medication. The intervention group received a standard CMAM protocol as well as a wash kit consisting of a 20 liters water container with tap, chlorine tablet with 3 bars of soap, and hygiene education material. The pre-specified theory of change for the project describes the hypothesized mechanism of change under which we would expect to observe an effect. Firstly, the wash kit was correctly deployed in the health center and provided to the parent of the SAM child at the start of treatment. Secondly, the wash kit was used by the caregiver and led to an improvement in household water quality and hygiene practices. Third, the improvement in quality of drinking water and caregiver hygiene practices led to a reduction in exposure to enteric pathogens and an associated reduction in diarrheal disease. And finally, if all this happen, that it will lead to an improvement in some recovery rates. During the implementation of study, 3 main challenges were encountered. First of all, flooding, which impacted the health center accessibility and therefore monitoring of the trial. Transhumance of mainly nomadic pastoral population, which led to dropouts before the end of the SAM treatment. And 2 national strikes of the healthcare system, which led to the extension of enrollment phase and therefore cost. Enrollment for the trial was planned to begin in 2019 for 12 months. The start was delayed due to the COVID pandemic, and enrollment continued for 26 months to meet our pre-specified sample size due to the challenges above. 86 clusters were enrolled with 43 in both control arm and intervention arm. We enrolled 2,411 children between December 2021 to February 2023, of which 835 abandoned the CMAM program before exit. No clusters withdrew from the study. I'm now going to present the preliminary results following the theory of change and looking at the various results to see if these hypotheses are verified. This means looking at the fidelity of the intervention to see if the wash kit was received correctly, adherence to see if the kit was used correctly, water contamination by arms to see if the use of the kit resulted in an improvement in drinking water quality, result on diarrhea to see if there was a reduction in diarrheal disease due to the intervention, And finally, if this resulted in an improvement in some treatment outcomes. Among the 2,411 SAM children included in TISA trials, 445 drinking water samples were collected and a questionnaire was administered at household level. The samples were analyzed for turbidity, residual chlorine, Escherichia coli, and total coliforms. 100% of the 445 households surveyed responded. Of these respondents, 94% of participants in the intervention arm received a wash kit and 72% treated their water, with the presence of aquatabs noted in 68% of cases. In the control arm, only 7% of households treated their water and only 1% had aquatabs. This indicates good fidelity and compliance to the TISA intervention. The result shows that turbidity was the same in both arms, which is normal since chlorination does not affect turbidity, but important because chlorination alone will not be as effective under high turbidity. Chlorine residual was higher in the intervention group, with a median of 0.5 milligram per liter compared with 0.1 milligram per liter in the control group. This is consistent with most participants in the intervention group treating their water with aquatabs. This graph shows the presence of E. coli in both arms. We know E. coli is a type of bacteria included in total coliform. It comes only from fecal matter and is therefore a much better indicator of human or animal fecal contamination. There was a significant difference between the control and intervention arms, with the intervention group showing a lower risk of E. coli contamination. Nevertheless, this is still a relatively high level of contamination. The control arm had an average of 250 colony forming unit per 100 milliliters, compared to 95 CFU for the intervention. If we place these figures in the context of WHO guidelines, a value of less than 100 CFU represents a medium risk, while a value of more than 100 represents a high risk. The prevalence of diarrhea at 8 weeks follow-up was 20 in the control group and 12.5% in the intervention group, with much lower odds in diarrhea in the intervention arm compared to the second arm, with an adjusted odds ratio at 0.36. At a 4-week follow-up, we continue to witness a notable difference, with the adjusted odds ratio for diarrheal disease standing at 0.57. Moreover, it's noteworthy that these findings are consistent with what we have observed in registry recorded cases of diarrheal disease. And while this burden of diarrhea is less as we would expect in adults versus children, we see a similar effect on diarrhea among caregivers. For confirmed recovery based on our anthropometrical criteria, there was no difference between arms, with 39% recovery rate in both. For recovery as recorded by nurses in healthcare facilities, 54.1% recovered in the control arm versus 60% in the intervention arm. There was no statistical evidence for a true difference. Concerning the secondary outcomes, weight gain of 4.06 grams per kilogram per day in control arm and 4.38 grams per kilogram per day in the intervention arm. 16 participants were referred in the control arm and 13 in the intervention arm, 4 deaths in the control arm and 3 deaths in the intervention one. There was no statistical evidence for a difference between arms. In summary, we can say that a large complex trial has been successfully implemented under challenging circumstances. The intervention was successful with the wash kit available, well provided and used. There is a difference in chlorine presence and microbial water quality between arms. A striking dissimilarity has been observed between the groups regarding diarrheal disease incidence, and this dissimilarity carries statistical significance. While there exists a discernible variance in the outcomes of severe acute malnutrition between the groups, it's important to note that this variance, though present, does not reach statistical significance. Thank you.